Okay, we're going to go for the first question. Does the removal of C1 create CCI?
I'll defer to
Robert,
Paolo.
you go first. All right,
Paolo's
fine.
the expert.
Opening C1 not necessarily leads to craniocervical instability, but can lead to craniocervical instability under certain circumstances. One of which, for example, is a massively retroflex odontoid, or past history of severe trauma, or if the patient has a severe connective tissue disorder. So all these things, but it's not an automatic thing.
Does anybody else want to add anything to that?
Jorge?
No, I am so far from the clinical practice that I will not dare to use this. I listen to you. I'm learning from you.
So, Patrice, in the pediatric setting, assuming, and Paolo pointed this out, that there isn't any inherent instability, judicious removal of C1 should not cause any additional problems. And obviously, you need to know ahead of time. If you're worried about kids with EDS, you definitely want to make sure they're stable. But again, within reason, more towards the midline, you should be fine with that.
Okay, great. Thank you. Next question, would anti-inflammatory diet help?
What is an anti-inflammatory diet?
I think that question is more for Dr. Stein, because he was talking about, small fiber neuropathy and other elements. It's not so much for us.
Okay, so there's one on Botox and muscles. Would you want to answer that one? Can Botox treatments in the neck help with loose ligaments or muscles in CCI? Would it cause any issues long-term if the Botox is injected in the same place every time?
Actually, it's the opposite. First of all, if somebody has, all depends what kind of craniocervical instability you have. In this case, since they're narrowing the issue on the loose ligaments, injecting Botox kind of weakens, because that's what the Botox does, the muscles, which are to a point taking over the stabilizing property that the ligaments have abdicated, since the ligaments in these patients are weak. So doing too much Botox is not really a great idea. On the other hand, there are some forms of treatment in which the ligaments are injected, like prolotherapy. In my experience, doesn't work very often. It works episodically in some patients, and for sure does not work in patients with more than mild or more than moderate instability.
Okay. Is there any activities we must avoid? Going to amusement parks, flying, and so on?
Well, I get that question a lot, especially with the kids. There's not a lot written on this, but there's certainly lots of anecdotal stories of kids going on a 4G roller coaster ride, or God forbid, a trampoline or bouncy house, and they come in with significant challenge and whatnot. Again, for someone that may or may not be stable, or someone that has a tight craniocervical junction, and intuitively it makes sense to avoid that stuff. I've certainly seen it anecdotally, and I generally try to discourage the kids from doing the biggest roller coaster, but there's not a lot written out there that I'm aware of, and I'm certainly open to any input from the panel.
Well, there are some of our colleagues have been either very restrictive or very generous. I remember that Tellenbogen once operating on a patient who was a defensive tackle of the Seattle professional football team, and then he cleared it back for activity. Other people are more restricted, and they say absolutely don't go on the trampoline. So I think that there is a big range of. I guess that you get influenced by the last time you got burned or the last time you got lucky.
Yeah.
Yeah, I actually get the question. Scuba divers. I've had like 2 scuba divers with Chiari, and I looked through the literature, and I don't think I could find anything in particular to say for positive or for negative in terms of allowing them. So there are all sorts of situations I think that come up that we don't know about.
Well, that, I've seen a number of patients over the course of the last 20 plus years, and there is a difference between snorkeling and scuba divers. Snorkeling, definitely not a problem for Chiari, but I had a number of patients who went scuba diving below 20 meters and lower, and they,
I guess with the
and they got in trouble.
pressure,
And they got in trouble.
Yeah.
So I do not know how many of my patients actually went scuba diving, didn't tell me. But those patients who told me, because they were kind of with symptoms, they were pretty much a problem. So I kind of tell people, like, if you're planning to do it, maybe it's not a great idea. But for many of these activities, including the roller coaster, it's like a very optimistic form of Russian roulette. Russian roulette, you blow your brains out in 1 out of 6 chances. Here, it's like having a big revolver with much more empty spots. So you can be lucky with that single roller coaster ride, or you can be unlucky. But my position is very similar to that one that Robert has.
Okay. This one I would say is for you, Dr. Stein. Are there any other treatments for neuropathy if you don't have improvement from medications mentioned or IVIG? Are more aggressive immunotherapies the next step?
Right. So it's a good question. I don't have a great answer. I mean, my approach is generally, IVIG is relatively benign in terms of its risk-benefit profile, aside really from the restrictive cost. When you start to talk about using other instances of immunotherapy, especially long-term, and especially now in the instance of COVID and everything like that, without evidence, it'd be very, you'd really need a strong evidence for some sort of, immune problem. There is an investigational drug. I think they're looking for sarcoid. It's termed AR90 right now, which is looking at regeneration of small fiber nerves. But I think if you failed IVIG, it's really a personal, you really have to weigh out the risk benefits very carefully of using anything further in terms of whether prednisone or whether other, plasma exchange or other types of immunotherapies.
Okay, thank you. Is scoliosis caused by Chiari or EDS? That's for anybody.
Yes. Well, again, all these are great questions, and they're all have multiple facets to them. Certainly, if someone has a Chiari malformation and a prominent syrinx, we see a lot of teenagers presenting with the MRI scan after the scoliosis is presented, and sure enough, they have a holochord syrinx or a large syrinx. There are also patients out there with scoliosis without a syrinx and a Chiari, and there's some limited literature, and I would agree with this, that some of these patients actually do better when the Chiari is decompressed, even though they don't have a syrinx. So I think it's all over the place, but there's no question scoli and syrinxes, as well as Chiaris, often are concomitant. And EDS by itself, with or without a syrinx, and I presented that one case that had a significant scoli, are also having
which is early, right?
Scoliosis as well, and that's probably more of a neuromuscular imbalance. But there are a lot of things here I don't think we truly understand what's driving what. Is it the syrinx? Is it the Chiari? Is it a combination? Is it the EDS and so forth?
Yeah,
Thank you.
From my point of view, from what I have understood so far, and it's still a work in progress, it is yes to both. You cannot tell on a patient-by-patient basis, obviously, but in principle, they're both with two different mechanisms. Usually the Chiari that is causing a syrinx or not, from the works of Brockmeyer, is causing an asymmetry in the tone of the paraspinal muscles. So it is the muscle splinting the spine that become working asymmetrically, and that promotes the scoliosis. On the other hand, the EDS tends to have just loose ligaments that has no effect on the muscles, and that leads to that as well. The funny thing is that the Syringomyelia cavities tend to. Obviously, it's never say never, never say always in medicine. But the interesting part of scoliosis, which are secondary to Syringomyelia, is that they go in the opposite direction of what the scoliosis, the normal scoliosis and orthopedic finds. So instead of going towards the right is on the left or vice versa, they would always get confused. For some reason, people don't understand.
Okay, what is the best way to get fitted for a cervical collar if your local doctors are not knowledgeable about CCI or hypermobility?
That's irrelevant. You know, it doesn't, the local doctor doesn't need to know anything about it. They just need to find, they cannot just go to a place and get them off the shelf. They need a good place with, generally is an orthotic kind of place. And they just fit it in the same way it would fit a dress or a suit. It really doesn't matter if you have instability or not. You need a collar with a good fit.
Okay. When doing an EMG, for those with mild craniocervical instability, is there any evidence that physical therapy can help to stabilize the cranial cervical junction?
Robert, go ahead.
I'm not aware of any evidence. I'm sure there's stuff out there. I would argue that lots of the kids with EDS, if they follow a legitimate program of strengthening and stretching routines, subjectively seem to do a lot better. Fortunately, in my world of kids, the number of times or frequency of instability is relatively low. So I would defer to the other folks on that.
Yeah, the point is that physical therapy does help and is part of the conservative management, which is the only thing which is offered in terms of therapy to these patients with severe to moderate. You do not offer surgery, but the key is to do it consistently. You cannot just go 2 or 3 times to the physical therapist and then expect the results. It's like preparing for the marathon and just running a couple of times around the block. And the important thing is to do it over and over, 15 to 20 minutes a day. 10, 15 is okay, but it has to be every day for several months before you actually make a dent in that. Talking about 6 to 9 months minimum before you see a problem, before a difference.
When doing an EMG and a nerve test, should the patient still be taking pain medication, muscle relaxer, nerve medication? By taking all of these medications, wouldn't the results be incorrect?
No, actually not. We certainly, and I encourage my patients to take their pain medications because you want them it's an uncomfortable test, so you want them as comfortable as possible. They take peripheral nerves. It takes a lot of medication before, and we see this with anesthesia studies. It takes a lot of anesthesia before we even see nerves really be, slow down. So just your usual pain medications or muscle relaxants should not appreciably affect the test.
Thank you. How do you know if you have cranial cervical instability? Would that have been obvious when Chiari was diagnosed?
That's yours, Paolo.
Thank you very much. Okay, I already said before, there are different kind of those instability which are obvious and straightforward. Everybody plus the medical student is going to get it. For all the others which are not straightforward, every specialist is going to have his own recipe based on his own past experience. Would have been obvious when Chiari was diagnosed. What we know is the byproduct of what we have learned before and how many times you got eggs on the face. So we cannot go 10 years in the future, like in the movies, and learn the lessons we're going to know back then. How many times did they miss things that now with the 10 years older self, I would have picked before. This is still something which is still dynamic and is still growing. So the answer we're going to have today is not going to answer we're going to have later.
Okay. Thoughts on acquired Chiari? What is the consensus in 2020 within the medical community?
It's a great question. And certainly seeing kids and older kids, young adults, and we're actually wrapping up, hopefully in the next month, a comparison between adults and kids in the DC area here. they're different conditions. And I think when you have kids that are 3 years old presenting or 8 years old, they have different symptoms, they have different issues versus a 27-year-old young lady. There very well could be the congenital variant versus the acquired over time or the EDS component. So back to the real question, what's the pathogenesis of the x-ray, and how do you explain the symptoms relative to the x-ray and try to put them together? But I think there are different approaches to this as far as the etiology, and I think that's part of it right there. And if Dr. Lazareff had any thoughts on that, or any of the other guys.
Yeah. In general, I think that looking at the literature of how Chiari, the idea of Chiari evolved since 1930, I will not be surprised if we jump to understanding in a more physiological way, So those different patients that we see, patients who feel this or feel that, yes, and they do have headaches with the Valsalva, but then all of the other symptoms might sometimes improve, So yes, as you can see, a very generous non-answer. I'm running for office.
You're elected.
I'm elected. Thank you.
Thank you. Is Raynauds considered a neuropathy? Is it an autoimmune disease? Is it prevalent in Chiari or more unrelated?
So as far as what it's considered, it's not a neuropathy. I mean, most people with Raynauds have normal nerve conduction studies. It's more of an autoimmune related disorder. So it has to do with the ability of the peripheral arteries they're not responding in the right way. I mean, it's nerve mediated in that it may be associated with small fibers and things like that. But basically, when there's a signal for cold and we want the nerves, the arterioles to vasodilate, they vasoconstrict instead. Is it, it's certainly associated with autoimmune disorders. Whether it's more prevalent in Chiari, I don't know. It's such a prevalent thing. If you really ask people, it would be hard to determine that.
Okay, thank you. This is for Dr. Bolognese. Do you still use an acrylic titanium mesh plate?
The answer is yes or no. In the past, Mirat and I were using the titanium with acrylic plate, aka the cranioplasty, for all the cases for something like 4 or 5 years. Then we did an analysis of the outcomes, and we started doing it on a PRM basis. And the funny thing is that when we stopped doing it on every patient, a number of our colleagues started doing it on every patient. So as you see, everybody has their own recipe and their way to move in the kitchen.
Rounded versus pointed tonsils. What causes the difference, and what does that mean to the doctor?
Jorge, you go first.
Yes, again, this is the slavery of anatomy, I mean, that we are paying attention to the small detail, the anatomical detail, It's like asking if a 6 feet and so many inches basketball player is better than one that is only 6 feet tall, Everything is in the action, And I don't see there is any other difference, in my opinion.
Okay, thank you. I have been told that if you are too cold during an EMG or NCS, you can get false results. I am wondering if you are too warm, can you also get false results?
So the reason we want patients' limbs warm is because everything is compared to normative values. So as you cool nerves, they can run a little bit slower. I don't think you could be too warm because, generally, we just basically, what we're trained is to have the limbs above 32 or 31 to 32 degrees centigrade, but I don't know of any literature that says that you could be too warm.
Thank you. Endoscopic versus traditional decompression. Isn't less invasive procedure better for the patient? Why isn't endoscopic more widely used as a standard?
That's mostly a pediatric field, so you guys go first.
Well, I don't know if it's pediatric or not because we don't do it. Ultimately, everything comes down to risk versus benefit. And certainly minimally invasive or less invasive approaches, if they provide the same or more benefit, would be attractive. And I think that comes down to, you know, the open versus closed, bone only versus duroplasty. It goes back to the question, why are the tonsils low and what are you trying to fix? You're not trying to fix the picture, you're trying to fix the cause for why those tonsils are low. And as you've heard from a number of the folks here on the panel and others, that's where the money is. So if endoscopic is giving you an equivalent or better result with less risk, you would go for it. But there's not a lot of literature that uniformly supports that. And there are a number of folks out there that do much less invasive procedures, less CSF leak, less infection, less pain. As a pediatric neurosurgeon, we're all for minimally or non-invasive approaches, and there's nothing wrong with that, but you've got to demonstrate a commensurate similar outcomes or better outcomes to support the less invasive approach.
Yeah.
The experience of the Cleveland Clinic, they did it for about 2 or 3 years, and they had some limitations. They were having good results for a short term, and the other limitation of their experience was the fact that the endoscopic approach was quite limited. You could not do all the things. So if during the surgery you were having a complication, you had to turn it to an open procedure. And the other thing is that if what you were doing in the dents you have with the pathology, you do one move and the more of a chess game than a dance, the pathology throws you a curveball. With the endoscopic procedure, you could not do past a certain level of complexity. Jorge.
I will quote here Rick Basdorf, but not talking about this issue in general. He always said that small incisions, big complications.
That sounds like Dr. Badstorff. I like that.
Okay, the next question is for Dr. Bolognese. Tethered cords impact on CCI.
Okay, that's it. All right, there are two things. There is the perception sometimes that when you have the coexistence of these two pathologies, cranial cervical instability and tethered cord, which appears in some patients, that after one surgery, the symptoms on the opposite part of the body become more intense. Okay, if you do a cranial cervical instability and extraction, that means you pull up, and on the opposite side of the cord there is a tight phylum which pulls in the opposite direction. Obviously, you're going to play tug of war. So that is mechanically is easier to understand, even if there are a lot of other problems like the dental ligaments and nerve roots, etc., and the fact that the viscosity of the spinal cord that kind of put some limit to this analogy. On the other hand, cutting the phylum has zero effects on the anatomy of the cranial-cervical junction or on the cervical-medullary junction. Therefore, there is really no the tethered cord by itself or the surgery aimed at the tethered cord does not have an effect on the stability of the junction. Can have some effect on the distally on the cervical medullary junction, but that is quite rare. That has been actually doubted by some anatomical studies done in autopsies by the people at the University of Alabama. So that key is still open. One easier way to explain this kind of symptomatic shift, it could be explained with a stupid example, which is if you have a toothache, but somebody steps hard on your foot, all of a sudden your brain gets distracted by the foot. So there is also this kind of stupid simpler and explanations would go in the middle, but it's still an open debate.
Okay, thank you. How do you know where to take the biopsy for small fiber? Does the level of neuropathy differ in different areas of the body?
So we use standard position. So I go 13 centimeters off the ankle and about 13 centimeters from the knee upwards for the thigh. So we want to keep those pretty standardized because, again, when we're looking at the intraepidermal nerve fiber densities, we're comparing them against normative values. So you want to standardize things as much as possible. Some people use the foot. I find it very painful. At least what I've been told by patients, it's a very painful site, so I tend not to use it. Some people also do an upper thigh. So like I said, we use the two sites in two. We use multiple sites in two ways. Firstly, if you have two sites that are positive, it raises your specificity. The second thing is that sometimes we can look at a pattern of illness. So if you have diffuse small fiber nerve loss, that falls into one category. If you have it length dependent, meaning that more effect in the thigh, less effect in the calf, that's another pattern. Or non-length dependent, meaning that the thigh has more loss than the calf, that would be another pattern. Or if you just have autonomic loss by seeing the sweat fibers lost, that would be another pattern. And where that's important for us is sometimes in trying to figure out the etiology. So, for instance, diabetes would be a more length-dependent process versus autoimmune diseases, which would be a more non-length dependent process. So it might focus your workup a little bit. But other than that, it's not always, the rules aren't always 100%.
Thank you. Are there any other findings to disorders, diseases that all CM patients have and are automatically connected to CM? Anyone?
Jorge, is more of a philosophic.
I think it's a loaded
You're all
question.
thinking, I know.
No, there's no
Jorge,
blood test
go
that
ahead.
says you have it.
Can you rephrase the question again? I had a problem with audio.
Okay. Are there any? So what they're saying, are there any findings to disorders or diseases that all CM patients have and are automatically connected to Chiari?
That is a great question, and I will write it down now, and I will work on a meaningful answer, which I will answer to you. Yes, we are working on that with the idea with a couple of the students, Andrea O'Riordan, undergrad here at UCLA, in seeing exactly what are the other diseases that we pinpoint to the Chiari. Going back again to the example of Semmelweis and the washing the hands, and which, by the way, I always say, Oliver Wendell Holmes thought of that 30 years before Semmelweis. But the washing the hands, we are washing our hands because of the cadaveric material. No, we are not washing the hands cadaveric material. We're washing the hands because of the bacteria. And once we understand the reason why, and I feel that something similar will happen to the Chiari. We will continue doing the same treatment that we are doing now, but with a better understanding of the anatomy, physiology, and the pathology. Yes, I will answer that. The question, give me 2 or 3 months. We're working on that.
Okay, thank you. This is going to be the last question because it's 12:30 and we need to send everybody off to lunch. So the question is, can having too much histamine affect neuropathy?
We know that histamine is involved with certain releases of substance P and a calcitonin gene-related peptide. So I don't know if it directly causes neuropathy, but it may certainly exacerbate symptoms of neuropathy. I don't know too much about a literature about histamine and neuropathy. I don't think there's anything that would say that it would cause neuropathy.
Okay. The rest of the questions we will have answered, and they'll be put on the website, just so everybody knows. And I want to thank all the panel for coming and helping us out here and answering all these questions. You can now enjoy your
Bye,
lunch.
guys.
Thank you very much.
Nice to see you.
Thank you.
Bye, Robert.
Bye.
Paolo.
Have a good day.
See you. Goodbye.
Bye,
Bye-bye.
everybody. It was a pleasure.